Assalamu alaikum. Today we'll talk about evolution of lower urinary tract symptoms. The term lower urinary tract symptoms encompasses the and a range of irritative storage and obstructive voiding difficulties. The phrase is purposely gender non-specific and does not presume an anatomical site of origin for the symptoms. Before these symptoms were uh, uh, Before these symptoms were called prostatism, because those symptoms were just referring to male patients. But there are different symptoms in which are suffered by females and young childs which do not have prostate issues. So therefore, the term lower urinary tract symptoms were specified. The storage symptoms are urgency, frequency, nocturia, urinary incontinence, and voiding symptoms are hesitancy, intermittent urination, straining, poor flow, and post-micturition symptoms are post-void dribblings and sense of incomplete bladder emptying. The lower urinary tract is composed of bladder and urethra, and the function is urinary storage and bladder emptying. Bladder filling and storage requires increase accommodation of increasing volume of urine at lower detrusor pressure, and a bladder outlet that is closed at the rest, and absence of involuntary bladder contractions. And bladder emptying or avoiding phase requires contraction of bladder smooth muscles, lowering of resistance at the level of sphincter, and absence of any anatomical obstruction. These are the factors affect which causing the lower urinary tract symptoms. Those are CA bladder, neurogenic bladder, cystitis, bladder stones, uh, prostate enlargement, benign prostatic hyperplasia, prostate cancer, prostatitis, urethral strictures, constipation. Uh, It's another diagrammatical presentation of LUTs, which distal ureteric stones, bladder tumor, urethral strictures, UTIs, neurogenic bladder, chronic pelvic pain syndrome, nocturnal polyuria, overactive bladder, or detrusor underactivity. The urinary frequency. Urinary frequency is the need to urinate many times during a day. Urinary frequency and polyuria is distinguished from one another is that urine output for more than 3 liter per day is referred as polyuria. And the normal number of time to urinate per day is about 4 to 7 times in 24-hour period. Nocturia is defined as waking up because the desire of voiding during intermittent sleep. It can be result as of an abnormality in the urinary tract or a symptoms of an underlying medical condition. Urinary urgency is a sudden urge to urinate. It is due to involuntary contraction of bladder muscles. Urinary urgency is one of the hallmark of symptoms of urinary tract infection. Dysuria is a painful urination that is usually caused by inflammation. The pain is usually not felt over the bladder but is commonly referred to the urethral meatus. Pain occurring at the start of urination may indicate urethral pathology, and at the end of micturition, it is usually of bladder origin. It is usually accompanied by frequency and urgency. Intermittency is unable to maintain a urinary stream. It is called intermittency. Post-void leakage or dribbling. This condition evokes complaints of involuntary leakage of urine following the completion of micturition and occurring after the patient has dressed himself, usually after he left the toilet. Hesitancy, trouble to start to urinate or maintaining urine flow. It can occur in men, women at any age, but it is most common in older men. Urinary incontinence is the involuntary leakage of urine. It means the person urinates when they do not want to. Control over the urinary sphincter is either lost or weakened. It is most common in women. There are most mainly four general types of urinary incontinence. One is stress incontinence. The activity it is also called referred as activity related incontinence. It is the most common type of urinary incontinence caused by straining on bladder, like jumping, bending, lifting, exercise, and even coughing or sneezing. Being overweight is also a cause of it. A weak pelvic floor muscle is another cause. Stress urinary incontinence occurs when the intra-abdominal pressure exceeds the intra-urethral pressure. It is most common in women. The urgency incontinence or urge incontinence. It is also this condition causes the bladder muscles to contract and signal a need to urinate even the bladder is empty. It causes an urge to urinate immediately and may cause accidents if patient doesn't make it to restroom in time. It's part of overactive bladder syndrome, and 90% of men who experience urgent incontinence will have detrusor overactivity. Overflow incontinence. Overflow incontinence occurs when the body makes more urine than the bladder can hold. This may also occur if the bladder is full and cannot empty, which causes it to leak. The bladder muscle may not squeeze as it should be. Overflow incontinence causes frequent urination in small amounts and constant dribbling. This type is more common in men and often associated with prostate surgery or prostate problems. The mixed incontinence complain of involuntary leakage associated with urgency and also with exertion, effort, sneezing, and coughing. Those patient with there are some patient who presents with both urge incontinence and stress incontinence. Functional incontinence occurs when other diseases or disabilities like arthritis or dementia make it difficult to get to the patient to toilet. Nocturnal enuresis is a complaint of involuntary loss of urine that occurs during sleep. It has estimated prevalence of nearly 10% in child under the age of 7 years. However, 2 to 3% of child may persist into adulthood. Nocturnal enuresis may also manifest later in life, and it is an important symptom, especially in men, as it may indicate that their men are in high pressure chronic urinary retention, which is usually associated with upper tract dilatation and risk of renal failure. Postural incontinence is a voluntary loss of urine associated with change of body position. Continuous urinary incontinence describe the complaint of continuous loss of urine. It is a rare symptom and only exists when there is a fistula. The complaint of urinary incontinence in which the patient is unaware of how it occurred is insensible incontinence. These are symptoms. These lower urinary tract symptoms are assessed by IPSS score. It is a performer which is asked from the patient, and the score if the score is 0 to 7, the symptoms are mild, graded as mild. If the score is 8 to 19, it is graded as moderate, and 20 to 35, it is these are severe. In history, after biodata, we will ask the symptoms of the patient, that either he is having storage symptoms, voiding symptoms, or post-micturition symptoms, the duration of those symptoms, the severity, we will ask about which symptom is most bothersome. And those symptoms, its impact on his life quality, and any precipitating factors or relieving factors. We will ask about the amount of fluid, the intake of amount of fluid, and type of fluid intake, urinary color, and timing of fluids, especially in the late evening or at night. Any previous drug history like diuretics or any herbal medications, and other comorbids, like neurological disorders, previous trauma, or previous surgery, pelvic surgeries. Neurologic conditions such as Parkinson disease, multiple sclerosis, stroke, spinal cord injury, back surgeries, myelodysplasia can have considerable impact on lower urinary tract symptoms, for lower urinary tract function. Diabetes, dementia can also affect continence. The radiation therapy or neurological can affect lower urinary tract function, especially with regard to outlet resistance or bladder contractility and stability. In women, gynecologic and obstetric history is very important. The previous pelvic surgery can affect lower urinary tract function. Anti-incontinence surgeries and hysterectomy can contribute to a variety of urinary symptoms. And now the examination. The general appearance of patient, including age, gait, stature, and fragility, can provide important information regarding performance status, neurologic status, and other factors that may direct proper treatment planning. The abdominal examination will look for incision, hernias, organomegaly, bladder distension. The DRE is important in these patients, and genital examination. Then the bladder diary. The bladder diary is a vital investigation tool as it provides objective information on the number of episodes the patient is passing urine during the day and night. The average and maximum voided volume and hence bladder capacity, the type and amount of fluid being drunk, the assessment of nocturnal polyuria, and whether or not there is any urgency. A 3-day bladder diary would offer. Here we can see it's a bladder diary. The patient mentions date and time, the type and amount of fluid which he is drinking, the volume of urine in mLs, the symptoms, the urgency, leakage with urgency, leakage with activities, and if patient is in diaper, the change of diapers. And uroflowmetry is performed. It's a simple test diagnostic screening procedure used to calculate the flow rate of urine over time. The test is non-invasive and may be used to assess bladder and sphincter function. In person with a urinary tract obstruction, this pattern of flow is altered and increases and decreases more gradually. It's a UFM machine which is connected. Uh, which is connected with a recorder. The signal goes to the recorder, and the graph is made. Certain factors or condition may interfere with the accuracy of UFM, like straining with urination, body movements during urination, and certain medications which affect bladder and sphincter muscle tone. The the normal uroflowmetry graph is bell shaped, in which we see the Qmax. Here are different graphs. The graph number one shows a normal curve. It's a normal UFM pattern. It's a bell shape, and it's a prolonged curve, mostly seen in benign prostatic hyperplasia. And the intermittent flow curve shows neurogenic bladder pattern because it is associated with abdominal straining. And a box shaped curve in urethral strictures. If UFM
Actually, the message is going there. This is how BPH will present usually, but intermittency is also part of BPH. What happens that these lateral lobes, when the patient relaxes his sphincter, the lateral lobes do not allow the urine to pass through, and a very poor stream comes out. That is why there is a flattening of the curve. But when the patient starts to strain, those lateral lobes close the urethral opening, the urethral lumen. So the flow drops, and when he relaxes again, the flow starts again. So you can have intermittency in this graph as well in cases of BPH as well. So it's not always that you see a continuous low flow graph in cases of BPH.
If Qmax is less than 10 ml per second, there is chances of obstruction more than 90%, and 10 to 14 ml shows around 76% of risk of obstruction, and more than 15 is the chances are less, and less than 30% of cases. And then we see the post-word residue. The volume of urine left in bladder after routine warding is termed as a post-word residual volume. This simple test, which can be performed via in and out of catheterization or using non-invasive transabdominal ultrasound, evaluates the bladder emptying ability and can be helpful in the diagnosis. The clinician considering in patients with stress urinary incontinence should assess post-word residue to evaluate bladder emptying, because patients with elevated post-word residue pre-op are at increased risk for developing voiding difficulties post-operative. Post-word residue less than 50 ml represent adequate emptying, and greater than 200 ml represents inadequate emptying.
Thank you, Dr. Salim.